Next speaker is going to be our Manisha Agarwal, and she's going to talk about exudative retinal detachment in uveitis.
So a very good morning to all of you. In the coming few minutes, I would be speaking on association of exudative retinal detachment in various uveitic entities. So we must understand that exudative RD is a potential complication of any ocular inflammation, and it is primarily because of the damage to the retinal blood vessels or RPE secondary to inflammation. However, the site of inflammation is extremely important in predicting the risk of development of an exudative RD. And if you have inflammation involving the posterior uvea, it has a higher propensity to develop exudative retinal detachment. Examples being a posterior scleritis, a posterior uveitis, and panuveitis. The common causes of exudative detachment in uveitis can be
Manisha,
any one of these.
Are you forwarding the slides? Because
yes, I am. Sorry.
There it's not. I thought you were just introducing.
No, I'm very much forwarding it here.
Can you move?
Can the
slides,
AV team
please?
help me with forwarding of the slides?
Yeah, there are. I'm looking at it.
Thank you for telling me that, ma'am. I didn't notice. So these are the common causes of exudative retinal detachment in uveitis, and this is the list of differentials that you should have in mind. As far as eye diseases are concerned, the most common being a posterior scleritis, a multifocal choroiditis, APM PPE, primary or secondary panuveitis, sympathetic ophthalmia, TB, and masquerades. And systemic diseases, we can have VKH, rheumatoid arthritis, and SLE. I'll just give you a few case examples. This is a young female with diminution of vision in right eye for last 1 week along with headache. And what you find is a pocket of fluid with ILM striae with a hyperemic disc in the right eye. And when you do an OCT, you have a bumpy RPE and choroid with a pocket of the fluid. However, what you see in the other eye, which is appearing to be normal, that there's an evidence of a choroidal thickening. And when you do a fundus fluorescein angiography, you do see hypofluorescence secondary to a choroidal inflammation, and you do have multiple pinpoint leaks which are suggestive of an inflammatory pathology. So this patient is actually having acute VKH and treated with IVMP followed by oral steroids and immunosuppression, and she is seen to be responding extremely well in as short a time as a week. This is another lady, 60-year-old female patient with pain and diminution of vision in the left eye. And again, what you see is exudative detachment at the posterior pole. And you have, again, a very bumpy RPE and choroid along with the pocket of the fluid. And when you do an FFA, you find that there are multiple leaks spread throughout the fundus with a hot disc, and some multiple pinpoint leaks are also appreciated. When you do a B scan, you do find an acute scleral thickening along with a very typical T sign suggestive of a posterior scleritis in this patient. So a clearance is taken from the physician and the patient is treated with IVMP followed by steroids. And this is the timeline of the patient where you see that the patient has recovered a good vision with complete resolution of the fluid at the posterior pole. This is another patient where the right eye was a thicycle eye and the left eye again shows an extensive exudative retinal detachment. And on slit lamp examination, you have a granulomatous KP and you also see retrolental cells. So this very much is suggestive of sympathetic ophthalmia treated again with high-dose steroids and immunosuppression. And though non-infectious etiologies is the title of this session, but I thought it would be incomplete if I don't show you an example of a TB granuloma, which again is very classically associated with an exudative retinal detachment. And we have done this work where we have treated these patients with anti-VEGF and moxifloxacin intravitreal injections. And you find that these patients have responded extremely well with complete resolution of the fluid and with the scarring and resolution of the granuloma. This is my last patient diagnosed to have VKH and treated with the high dose of steroids. and the patient was not responding, so she was subsequently treated with methotrexate, still not responding, so azathioprine was added. And there was really absolutely no relevant past systemic history. There was an extensive exudative retinal detachment that you find in the right eye. You also have a hyperemic disc which can confuse you with an inflammatory pathology. This is the left eye where you have again a total exudative retinal detachment with a subretinal gliotic band passing through the macular area. And when you do an OCT, you find that there is SRG bands with pockets of fluid. Anybody is likely to get confused with the diagnosis of a VKH in this patient. When you do a fundus fluorescein angiography, you again find a very hot disc with blurred margins, suggestive of an inflammatory pathology. You have these pinpoint leaks, again, which can confuse you with a VKH or a posterior scleritis. But what very strongly went against an inflammatory pathology was that this patient was not responding to steroids and also to the addition of 2 immunosuppressants in this patient. So we went back and reassessed the OCT of this patient where we were able to notice these very subtle choroidal bumps which went against the diagnosis of what had been done in the past. So when we went back to the patient again, a detailed history taking, she gave a history of a small nodule in the right breast 2 years back, which was diagnosed to be benign. And we referred her for a re-evaluation of this breast lump. And rightly so, she was diagnosed to have lumps in both the breasts with matted axillary lymph nodes. And after a battery of investigations, she was diagnosed to have metastatic carcinoma of the right breast with leptomeningeal metastasis and both high choroidal metastasis and bone metastasis. So to conclude, active inflammation is the key predictive factor associated with the development of an exudative retinal detachment, and it does require early and a vigorous control. Unlike a rhegmatogenous retinal detachment and a tractional RD, medical management is the mainstay of treatment for an exudative RD. However, exudative RD may have an underlying fatal condition, and therefore always remember to rule out the masquerades. Thank you so much for your patient listening.